Welcome, everyone. It's the third webinar hosted by Caixin Global on coronavirus. And before we start, again, let's give our highest respect to medical staffs around the world battling the virus, from Wuhan, from Italy, Spain, US, you name it. The soldiers risking their lives to save lives. And this webinar is for them. Hope the experiences can help governments take prompt actions proven to be effective to help medical staff to get ahead of the virus attack and be as prepared as possible and to inform the public what really happened on the front line. So we have two extraordinary speakers today. I'll introduce them separately. Dr. Peng Zhiyong, he's Director of Intensive Care Unit of Zhongnan Hospital of Wuhan University. On January 6th, he encountered his first COVID patient, and he immediately made the decision that the hospital and staff should switch to the highest alert. And the result, the ICUs under his leadership has probably the lowest COVID ICU mortality rate in Wuhan, about 20%, while the overall ICU mortality rate was about 25 to 30%. They also have much smaller ratio of medical worker infection. So how did he make that? We'll hear from him shortly. Another speaker we have today is Dr. Vernon Lee. He is the Director of Communicable Disease at the Singapore Ministry of Health. And Singapore has been applauded for successfully containing the virus spread while largely maintaining its economic activities. And you know better than anyone, Professor Lee, that the success is by no accident. I heard that on as early as January 2nd, I'll say the date again, January 2nd, 3 weeks before Wuhan lockdown, Singapore Ministry of Health issued an alert requiring precautionary measures in response to the severe disease in Wuhan. So how did you keep yourself ahead of the curve so you can successfully flatten the curve? So both Dr. Peng and Professor Lee have prepared detailed presentations. We'll start with Professor Lee first, and then Dr. Peng on the medical experiences. So Professor Lee will give you the control of the PowerPoint to you now. Please, the floor is yours. You have to unmute yourself, Professor Lee.
Yes, sorry. Thank you so much for the introduction. And I'm very happy to be here on this video conference to share our experiences here in Singapore with our colleagues in China and also to the rest of the world. Of course, our experience in Singapore is but one experience, and I'm sure there's also a lot of lessons to be learned from the experiences in China, which we'll hear later, and also from our other colleagues around the world who are fighting this coronavirus pandemic. As you have mentioned, I think we should dedicate this to all the frontline medical workers who are working tirelessly to combat this pandemic and to make the world a safer place. So I will just start with some slides. Give me 1 second. Okay, I'm trying to. Okay, it's not quite allowing me to share the slides. Oops.
Is it working now?
Nope, not quite. Support one screen. Is it possible for you to give me the control? Because that's the older set of slides. I'm trying to share the slides from my end.
Okay, try again.
Okay, no, that's the slides that you have. I have another set of slides that I have. Is it possible for me to put the slides on from my computer?
Did you press the share screen button on your computer?
Yeah, there's no such button here.
Under the Zoom on the bottom, there's Q&A, participants, Q&A, and share screen. If you press the share screen button, the green one.
Nope, it's not appearing somehow. Sorry, give me 1 second. Okay.
Now it's up.
Yep, now it's up.
Okay.
Okay, sorry about that. Okay, can you see this now?
Yes.
Okay. Sorry for the technical issues. Okay, so I'm just going to give a little presentation about our fight against the coronavirus pandemic, our policy analysis, and also our practical experiences here in Singapore. So just to show the current global situation, I think as of today, we have almost, I think, 500,000 cases globally. And you can see many of the countries with large number of cases now reported in Italy, the US, Spain, Germany, and so on across Europe. I think the large number of cases. In fact, cases in China, as I understand, there are very few local cases, if at all, and most of the cases are actually imported. So this is some plots showing the trajectories of the COVID-19 outbreak, starting from the number of days since each country had their 100th case. And you can see that after the 100th cases, many countries have had very sharp acceleration in the number of cases in those countries. So here's Europe and the USA. You can see that the trajectory is very sharp, with cases doubling every 2 to 3 days, and deaths as well, doubling at a very rapid rate. However, if you look at Asia, and the graph in blue is, of course, China, you can see that the measures that have been done in China to control the outbreak have been very successful. And in fact, the curve in China is rather flat at the moment, showing that it is possible to contain the spread of this virus, even within about 3 to 4 weeks. And you can see that at the bottom, there are countries that have overall kept the doubling of the, or rather kept the number of cases lower than the double every week line there. Singapore, Hong Kong, Japan being some of those cases, some of those countries. So there are some successes that we can learn from, whether it's China, Singapore, Hong Kong, or Japan. And I think this is something that would be interesting to share. Today, I'm going to share the Singapore experience, but I think other regions in the world, like, for example, Hong Kong, or even countries like China and Japan, would have other experiences to share as well. So what are some of the medical findings that we have learned from this virus, which underpins many of the strategies that we have done? One is that we have looked at the various pieces of data, and we realized that the main modes of transmission is mostly through droplet, when someone coughs or sneezes, or through contact with contaminated surfaces, and where there is, sort of a poor personal hygiene. However, there are also case reports of asymptomatic transmission. We've showed here 2 papers from China, where there is the possibility that asymptomatic transmission exists, but however, this is not the main mode of transmission, and there's still many people who are doing studies to look at pre-symptomatic transmission and also the asymptomatic proportion. The other thing that we are concerned about is viral shedding. And this is a graph from one of our early studies in Singapore. I know there's a lot of numbers there, but what it shows is that the virus shedding is high very early on in the course of the disease, and it drops down after many days of illness. What this means is that cases tend to be very virulent or are shedding a lot of virus very early on in about day 3, day 4 of their illness. And if these individuals are not captured or diagnosed early and isolated, they can actually spread disease very quickly. And that's why we see so much transmission across the world. The other interesting thing to note is also case fatality rate by age. And we put 2 sort of studies side by side. One is a study in China and the other a study in Italy, showing the case fatality rate by different age groups. As you can see, it is quite interesting to note that in individuals, in children and younger adults, the case fatality rate is actually quite low, but it climbs very steeply. And you can see that the case fatality rate in the elderly, especially above 70 and certainly above 80, approaches that of more than 10%. So this disease is not quite like other diseases like SARS or even the 1918 influenza pandemic, where there's a lot of concern that it affects younger individuals and young adults. This disease seems to have a predilection for older adults or the elderly, and also those who have comorbid medical conditions. So this is also something to note, whether the strategies should be focused on protecting elderly and those who have other medical conditions in the community. There are many studies out there right now being carried out in China, Hong Kong, Korea, the USA, and so on, looking at many different treatments. However, many of these trials are still ongoing, and we are still hoping to find an effective cure against coronavirus. Clinical trials on vaccines are also ongoing in many parts of the world, and there are in fact several candidate vaccines that are in preclinical testing. However, vaccines will still require another 6 to 18 months for clinical trials to complete before going to production. So I think having a vaccine that can be used worldwide in large quantities is still some time away. So where does this all take us then? What are the strategies that we can employ, given some of the data that we have seen, to combat the spread of coronavirus? One of the things that we have done in Singapore is in prioritizing the different tasks and resources. And to do this, Singapore actually has a coordinated whole of government effort in combating this virus. And this is not just set up during coronavirus, but it's actually been in place for several decades now. And we use this against a range of different threats that we face, and coronavirus being one of them. So very early on in January, we actually set up a multi-ministry task force to facilitate prioritization of tasks and also in inter-ministry collaboration. So for example, the Ministry of Health and the police have been working together on contact tracing activities. And these contact tracing would help us to identify as many cases as early as possible and to prevent spread from coronavirus cases. We've worked with the Ministry of Trade and Industry to have a coordinated procurement of different supplies, whether it be masks, laboratory supplies for our testing equipment, and so on, so that there is a single portal for all the requests for supplies in these very trying times. The Ministry of Communications, for example, coordinates our communication strategies. So they put out different messages to the public and also to professional groups so that communication is centralized and there is very rapid sharing of information as soon as possible. Other ministries, for example, Manpower Ministry develops workplace advisories. Ministry of Education coordinates, for example, physical distancing effort in schools, and also promoting tele-learning activities so that children can also learn from home if the need calls for. At this point in time, schools in Singapore are still open. And of course, there's a lot of support from the research community as well to develop new technologies, for example, serological testing platforms, or even point-of-care test kits for the future. So what are the measures we have introduced in Singapore across time that we have used to combat coronavirus? These are not measures that we have set out at a single point in time. What we have built across these measures across time, and these are the current set that we have in place. A couple of things to note is that schools in Singapore remain open, people are still going to work, and people are still allowed to go out. Food and beverage establishments, restaurants are still open, and people can continue their life, their daily life, with some precautions, and of course, some physical distancing. So there are 4 buckets of different measures that we've introduced in Singapore. The first bucket is in minimizing the risk of transmission and in enhancing surveillance. Ever since, as our host had mentioned earlier, 2nd of January, we have been encouraging medical practitioners and healthcare establishments to assist us in detecting every single case of coronavirus that we possibly can. So we have an expanded suspect case definition, which we have revised across time. We have an enhanced surveillance system where we test all pneumonia cases. We test cases with fever or acute respiratory infection that have not recovered. And we also test influenza-like illness cases as part of our surveillance system. So we continue to test and test until we find every single case. And when we find a case, we do our contact tracing and active case finding to find additional cases around them. And what we do then is every time we find a case, we isolate the case and we perform contact tracing to determine the source of that case and also close contacts who we place under quarantine or phone surveillance. This has been very effective in slowing down the spread of the epidemic in Singapore, or the outbreak in Singapore. The other thing that we have done is to activate our public health preparedness clinics, which have been in place for many years now, but we activate them every time there is a health crisis. And in this case, we activate them so that we can encourage the public to visit these clinics if they have fever or acute respiratory infection, so that these clinics are well supplied and they also know exactly what to do to manage these cases. The second stream of measures is in reducing the flow and imported cases into Singapore. To do so, we have set out travel advisories and also border restrictions for affected countries. And we have also set up measures at the border, such as temperature screening and health advisory notices to reduce or to identify cases as soon as possible. We are now swabbing and testing symptomatic travelers as they enter Singapore. And all travelers will also have to serve a 14-day stay-at-home notice. So they either have to stay at home or in the hotel for 14 days before they are allowed into the community. So those are the measures to prevent importation and to detect cases and to quarantine contacts. Now, the third stream of measures is about social or physical distancing. So for every individual who is ill with a fever or respiratory infection, we provide a 5-day compulsory medical leave where they have to stay at home so that they do not have the opportunity to spread any respiratory illness to others. We've also suspended events, mass gatherings, and religious activities to reduce opportunities for spread, closing entertainment facilities, and also currently limiting gatherings to less than 10 people, and to ensure physical distance of between 1 meter of individuals. But all this allows us to achieve a certain level of, like I mentioned, life as usual, so that people can go to work and people can go to school and still maintain their daily activities. And finally, we have a lot of messaging programs to encourage people to be socially responsible and to be transparent in our communications. So we have a lot of posters, TV programs to encourage good hygiene, social responsibility, open public communications where people can use normal standard media, also social media to obtain information, and also communications to healthcare workers. So just a few graphs showing the epidemic curve in Singapore. You can see that the cases in yellow and red are those where those are local transmission, and those local transmission, most of them are linked to previous cases. So you can see that the number is quite steady. And of course, the other blue and green colored bars are where there are imported residents who are returning from overseas, and we have to take them in. And of course, because they stay at home, we hope that they don't transmit to anyone else. By doing this, we have actually kept, in this case, a reproductive number. We have actually graphed it, and you can see here in the blue line, the reproductive number in Singapore has been kept mostly under 1, and it's currently about 0.5. So we are reducing the opportunities for spread in the community. More graphs showing that on the left, every day that you miss keeping a case in isolation or quarantine, that case in the community would have a greater opportunity to spread to secondary cases. So on the right, you can see that across time, what we've done is to reduce the time of isolation of cases from about 7 to 8 days and round about 3 to 4 days at this point in time. So we are isolating and quarantining cases much earlier, reducing opportunities for spread. So all of the measures done in Singapore is essentially risk-calibrated. We do not want to do too little, and we do not want to do too much such that your measures are out of proportion to the risk that we face. So what we have done then is to calibrate our policies according to the evidence, both epidemiological evidence and also other things that are happening both in Singapore and across the world. So there are different sorts of measures. There's a baseline measures such as personal hygiene and stay at home when unwell. This is sustainable for a very long period. To slow the pace of spread, prevent large clusters, we have another set of measures such as capping the size of events, telecommuting from work, enhanced measures for vulnerable groups. Then we have different measures to prevent accelerated spread, such as suspension of events, entertainment, and limiting the size of gatherings, which is where we are. And we hoped not to go to the stage where we have to control accelerated spread, which is the school and workplace closures that we have seen in elsewhere. So all of these 4 buckets, it's not a straight line that we must go from one to the other. It is different measures that we can use from time to time, depending on the situation. So we can move up or down, depending on how we feel that we are controlling the virus in Singapore. And right now, we're somewhere in between the 2nd and 3rd buckets because we feel that we have a handle on things here, but at the same time, we want to stay ahead of virus spread. We want to do a little bit more as precaution to prevent more transmission. And finally, hopefully, post-crisis, we're able to set a new normal where we are able to live with the virus through regional and global collaboration, and we can strengthen our pandemic preparedness and response, enhance our surveillance and response capabilities, and also expand our healthcare capabilities to deal with the future threats from coronavirus. So that's all I have today, and thank you so much for your time.
Thank you, Professor Lee. Before you go, before we turn to Dr. Peng, a quick clarification from our listeners. You mentioned we expect vaccine in 6 to 18 months, right?
Yes, that's what many experts have said, that by 6 to 18 months, you would see some of the vaccine trials being completed, and that's about the time when we think that there might be a viable vaccine. But it does not mean that there will be sufficient vaccine for the whole world, because even after vaccine is available, you still need to run them through production facilities. And that will take time for these production facilities to ramp up and have sufficient vaccines to be delivered to people globally.
Right. So manage the expectation. So now let's turn to Dr. Peng.
Hello, everyone. I'm Dr. Peng from Wuhan University, Zhongnan Hospital. It's my great honor to share my experience with you. Today, my topic is what we learned from COVID-19 outbreak in Wuhan. I'm a physician as well as medical researcher. I have no any conflict of interest to declare. I will briefly talk about the following contents. First, I will talk about how to prepare the outbreak of COVID-19. So in the early stage of the outbreak, the medical resources always limited, including the medical beds, ICU beds, medical professionals. And we need to mobilize the medical resources under the help of the government or the hospital authority, and try to organize the new teams to increase the ICU capacity and the approach in our hospital. We shut down the routine care except for the emergency care, and we move other non-COVID-19 non-COVID patients to one building, and keep other building open to the COVID-19 patients. And also for our ICU, we recruit the physicians from the other department, such as the anesthesia and the surgical department, because they have the similar training with us. And also we increased the ICU capacity from 1 ICU to 3 ICU to serve for the COVID-19 patients. Also, the personal protection is quite is top priority for our medical professionals. So we need to prepare the PPE, including the cap, gloves, gowns, masks, goggles, face shield, and hood. Also, we set the different levels of the precautions for droplet, close contact, or airborne. in my department, also we set up the protocols, protocols for the wearing the PPE or take off the PPE, because this is quite important to avoid infection from COVID-19. And also we monitor the ICU environment regularly for the possible virus pollution. Why this is important? Because the transmission is quite often in the hospital. So based on the reports published in the JAMA, and about the 138 patients in our hospital with the COVID-19, almost 40% of them infected in hospital, and most of them are medical workers. And the infected medical workers were from other department, not from ICU, not from ER, because the initial stage they didn't know the severity of the transmission, and also we haven't know enough PPE. Another issue is because the atypical patients or asymptomatic patients came to the our general ward, and then finally they were COVID-19 and they affected the medical professional there. Also, we need to set up the policy for triage, including the fever clinics, the ER, the general wards, and the ICUs. We have the different criteria for the hospital admission and ICU admission for the COVID-19. So about the general features of the COVID-19, this is our study from our 138 patients. So you can see the age and the comorbidities. And also, if we compare the severe cases in ICU and the non-severe cases in the general ward, and you can see the elderly people is relatively severe, and also the patients in the ICU complicated with much more comorbidities. And also about the symptoms, the most common symptoms for this patient is the fever, fatigue, dry cough, myalgia, and dyspnea. And about 10% of the patients presented initially with the asymptomatic, is like the abdominal symptoms. So finally, they developed the fever and the difficult breathing in the couple days. So this kind of patients easily infected our medical professionals in other departments. About the clinical process, the time from the first symptom to dyspnea was 5 days, and 7 days to hospital admission, and 8 days to development ARDS. The lab test for these patients, and the typical feature is lymphopenia. Most of the patients complicated lower lymphocyte counts. And the typical chest CT is glass opacity. So most of them occurred in the peripheral area. About the diagnosis of the COVID-19. So based on the exposure history and the typical symptoms, lab test, typical chest CT, and we can set up the clinical diagnosis for this kind of patients. And if the virus PCR test positive, and then we set up the confirmed diagnosis for these patients. So here is the different diagnosis criteria. I just mentioned the confirmed and clinical diagnosis. So about the management of the critical ill patients. So here is the features of the ICU patients. So you can see the opacity score and the SOVA score not so high compared to the other patients with ARDS. But if you see the p-value ratio is quite low, it's about 136. And also about the organ injury, most of the patients developed the ARDS, and also acute cardiac injury, and also some patients developed the shock and acute injury. So for the ventilation support, almost half of the patients requiring intubation, and the other 40% of them requiring non-invasive ventilation. So so here is the other patients from the February to March. So and also you see the the parameters is quite severe compared to the patient we just mentioned in the first month. The p-value ratio is around 115, and also increased IL-6 level, and also 70% of those patients requiring intubation, and only 28 of the patients survived from the non-invasive ventilation. And almost 90% of these patients developed ARDS, and almost 60% of them developed a cut injury, and 40% of them developed a shock, and 20% developed an acute injury. So about the ventilation supports, the key points are the following. So the non-protective approach is extremely important. We should focus on this approach, and we try to prolong this patient as early as possible, and evaluate the mode parameters regularly, and switch or change if not suitable. And also we titrate the PEEP and the tidal volume based on the transpulmonary pressure or driving pressure, and keep the driving pressure less than 15, and prevent acute Cor Pulmonale. Be careful of the non-recruitment maneuver. Set the highest PEEP around 20. So for this kind of patients, the PEEP level is relatively lower compared to the ARDS from other etiology. So here is the about the different modes of the ventilation. First, about the high flow nasal cannulation. So actually, I recommend this model in the room with the negative pressure. And if the p-value ratio is around 200 to 300, we can try the high flow. So that's the rate, and FL2 we choose, and we test for 2 hours, and to see the efficacy based on the LOX score. LOX score based on the respiratory rate, saturation, and FI2. So if the LOX score more than 3.8, continue. If less than 2.8, stop the high flow. About the non-invasive ventilation. So if the p-value ratio about 150 to 200, and we start the non-invasive ventilation. However, BiPAP may worsen the lung injury. So if the respiratory rate and the tidal volume is too high, will increase the transpulmonary pressure or driving pressure and worsen lung injury, and finally induce the pulmonary fibrosis. So initially we set the IPAP 12, EPAP 5 to 8, and also we tested for 2 hours. Also follow the tidal volume. If the tidal volume less than 9, continue. If more than 12, stop and intubate the patients. So if the P4 ratio less than 150, and then we will intubate the patients. And of course, we should test the patients is responsible to the recruitment maneuver. So usually we set the highest people around 20, and also we monitor the driving pressure. If the driving pressure more than 15, and we will paralyze the patients, and also with the prone position. We follow the non-compliance, and also we monitor the blood gas. If the P4 ratio is still 150, less than 150, or the patient development hypercapnia or acidosis, and then probably we will consider ECMO. So here I share a case with you. So this is the 64 years lady, and transferred to our ICU from other hospital due to the severe dyspnea and tachycardia. She was diagnosed with COVID-19 outside the hospital. She was healthy previously, and she received the antiviral medication as well as antibiotics for 5 days, and corticosteroids for 7 days. And also she received the non-invasive ventilation for 9 days. So this is the chart for her last 9 days non-invasive ventilation. And you can see that actually this ventilation actually didn't work for her, and probably will worsen her lungs. So when she arrived to our ICU, her heart rate 130, saturation 82%, respiratory rate 46, and blood pressure 130/82. And also we prepare for intubation, and also we immediately give her non-invasive ventilation with the 100% oxygen, and her ABG acidosis and the P4 ratio is less than 50, and carbon dioxide 55. So we intubated her, and with the tidal volume 400 people, 5. And also we give the pressure support 12, and also we measure the pleural pressure around 26, and her compliance only 20. So we give the muscle relaxants for her. Also prolong her, try to improve her oxygenation. And unfortunately, her situation become deteriorated, and her P4 ratio still going down, and also complicated with hypercapnia. Also developed hypertension, and we switched to ECMO for her. Also, we did the bedside echo for her, and you can see actually she complicated with the acute Cor Pulmonale. So her right ventricle become enlargement and also compromised her left ventricle. So induced the lower cardiac output. So her received the high dose of the norepinephrine. So this is before VV ECMO. So after VV ECMO, we also performed the bedside echo for her. So actually her situation improved with the improvement oxygenation. So the norepinephrine going down to 0.3 microlog per kilo per minute. And here is the sheet for the ECMO for her, and also you see in the next 9 days her condition slightly improved. So and then the swab rate going down, the flow rate also going down, and during the day 10 we wean off her ECMO. And also switch to the ventilation supports. Also, within 5 days, ventilation supports also try to wean off her, wean from the ventilators. So in the day 15, so we wean off her, we wean off from the ventilation, the mechanical ventilation and the accelerator. So the lessons we learned from this case. So I've emphasized that the long time of the non-invasive ventilation within the lung, so induced lung injury. So also the people said try to little bit lower compared to the other ARDS patients, and prevent acute Cor Pulmonale, because this was induced by the severe hypoxemia and subsequently hypertension. So if the hypoxemia was improved, the condition of the acute Cor Pulmonale will be improved. So here is the flow chart we set up for the patients with the COVID-19 for the ventilation support based on the PIF ratio, and then we monitor the parameters we set, and to follow up the changes of the ventilation, and then we determine to continue or change the ventilation modes. So lastly, I will talk about the outcome of the patients with severe ill COVID-19. So actually, the first 50 cases in our ICU in the January, the overall mortality is around 18, and also the next 50 cases we recruit from February to March, and also because this patient is quite severe, most of them was transferred from other hospitals, and the overall mortality is around 25 to 30%, but still quite low compared to the general mortality in Wuhan during this time. Based on the reports, the general mortality in Wuhan ICU is around almost 50%. So also we compared the dynamic changes of the lab test between the survivors and non-survivors, and you can see the non-survivors labeled in the red color. Have the persistent high level of the neutrophil counts, and the low level of the lymphocyte counts, and the high level of the D-dimer, high level of the urea, and high level of the creatinine. Also, we compare the dynamic changes of the vital signs and the other variables between the survivors and the non-survivors. And you can see the non-survivors marked in with the yellow color, also complicated with the high level of the carbon dioxide and also high level of the lung injury score, higher heart rates, and also requiring high dose of the muscular relaxants and high dose of the vasopressors. Also, we run the multi-variable analysis for the patients, and we found the aptitude score as well as the lung compliance predict the mortality for the patients in the ICU. In conclusion, so the preparation for the outbreak of COVID-19 is important. The transmission was frequent, especially in the hospital, and the atypical patients were probably the main source of the transmission. The critically ill patients tended to be older with more comorbidities and lab abnormalities titrating the most parameters of the ventilation supports with lung protective approach is crucial. The most common complications was ARDS, arrhythmia, and septic shock. Nearly half of the critical ill patients requiring invasive ventilation. The lung compliance is the first day of the intervention, and the persistently elevated carbon dioxide level predict poor outcome. Well, thank you for your attention. Thank you for inviting me.
Thank you, Dr. Peng, and we'll bring back Professor Lee as well. A lot of participants are asking whether this session will be recorded and the information will be available. The answer is yes. And so all the content, including the video replay, including the slides used by the two speakers, including the highlights from the session. Also, you asked a lot of questions. Not all of them will get a chance to answer now, but we'll have our speakers help answer them in written. And all of this will be published at caixinglobal.com. So come back and all this information will be available. And if you take a look at the final slide from Dr. Peng, I think the gentleman, the taller person on the right side is him in the hazmat suit. Is that right, Dr. Peng?
Yes, yes.
Actually, following this, one question from our audience is, how did you survive 12-hour shifts without eating, drinking, and using toilet in suits like this? And a more serious version of that actually is because protecting medical worker is our goal. And also we've seen a high infection rate among medical workers in a lot of places in Europe. And one audience is asking in Philippines that 9 out of the 30 deaths are physicians. How do we protect them?
Okay, so actually we have prepared a very good personal protection even in the early stage. And I fully understand that at the time the supply was limited, so we try to control the consumption of the personal protection equipment. So we assigned, 2 pairs for each medical professional one day. So it means they can only come out or ICU for one time, for lunch or for the restroom or for have a drink. So this is the very difficult situation for us. But actually we survived in this stage. So after 1 month, everything is okay. The supply of the PPE is enough, was enough. So actually, for the infection rate in our ICU is quite low. So far we have only 2 nurses infected, but only in the early stage. But the only one infected in the ICU. The other one infected outside the ICUs. So this is the medical for us, because in the early stage, the medical professional infected with the COVID-19 is quite over in the hospital.
And another question, which is also very technical, but I think it's very important for us to ask, from coming from Zurich, from the hospitals preparing for the influx of patients. So the audience is asking, is there any evidence putting patients in prone position has an impact? Because the reports that from Italy suggest that it didn't have much impact. And also, what's the experience with non-invasive ventilation? You just mentioned that briefly. Also from another audience from Australia says they heard that non-invasive ventilation has a high failure rate, but can it be used to buy time? Or is high flow nasal oxygen better device for respiratory failure?
Okay, so regarding the first question, what's the first question?
Is prone position?
Prone position. Okay, so it's actually for the prone position, we prone the patient a relatively longer time compared to other ARDS patients, because only in a short time, we couldn't find any improvement, but we should prolong for relatively longer time. So actually, so why we said try to prolong the patient as early as possible. So even the patient is still consciousness, we also ask the patient to prolong. So this is quite important to improve the oxygenation. And also the second question is about the non-invasive ventilation.
Non-invasive ventilation.
So yeah, so this is the very complicated questions. So regarding the high flow, I just mentioned the high flow. I'm also concerned about the safety used in high flow. So I highly recommend the high flow used only in the ICU with the negative pressure. So if only the regular ICU without any negative pressure, probably is not safe for the medical professionals working there, because we monitored the virus level in the ICU environment compared to the with the negative pressure or the regular ICU, because in my department I'm responsible for 3 ICUs, 2 ICUs equipped with the negative pressure, 1 ICU just open the window, nothing, and that ICU sometimes we detected the virus in the near the equipment, also in the air, also in the telephone, or in the surface of the ICU. So this is not safe for the for the people working in the ICU. So I highly recommend use the high flow only in the ICU environment with negative pressure. And also about the non-invasive ventilation, I just mentioned that this we should be carefully monitored how the patient responds to the non-invasive ventilation. So if the patient condition didn't improve, and probably we need to switch, to the invasive ventilation, because the non-invasive ventilation will probably worsen the lung injury I just mentioned. So the patient, the case I just shared, the case the lady received 9 days of the non-invasive ventilation, and actually her condition become worse and worse. So if the patient was in my ICU, we just follow for very short time, 2 hours. If not improved, and then we will intubate. We would intubate the patients.
Right. I will also switch to Professor Lee for more of a policy reaction question. I think it's now becoming consensus. More and more people are talking about that overreaction is better than unprepared in cases like this, or slow reaction. But can you talk about what prompts the Singapore government to act so early and switch everything on so early? Is that a result of many unknown overreactions out there that prepare them for cases like this? Or there is a scientific and very efficient monitoring system that can pick up the information very early on and translate that into action?
Sure. I think, as I mentioned earlier, it is definitely necessary to be prepared and to act to stay 1 or 2 steps ahead of the virus. Because a lot of the indicators that we're looking at are what we call lag indicators. So by the time we detect something, there were actually events that happened maybe a week ago. For example, any cases that we diagnose, the onset of symptoms may happen a week ago. Any transmissions that we find is a week ago. So we would need to do something that we think will prevent the infections from happening over the next few days or the next week, not something that happened yesterday. And in Singapore, many of the activities that we've done are in a way anticipatory. So if we see, for example, an increase in number of cases on some of our indicators, we try to do something to prevent more spread in the next few days. Of course, the measures that we're doing is also calibrated. So while we don't want to do too little, we don't want to go into the extreme to do too much as well, because this is not something that will go away quickly. It's not a sprint, it's a long marathon. So our measures that we put in place needs to be sustainable over the long run. So we are trying to do things that the population can accept and can deal with in the long term. And this includes things like asking them to be socially responsible, to making small changes to their daily routine. So that is what we have done so far. I think it is very important, just to emphasize again, that to be able to detect cases as early as possible to try to contain them, because if not, the outbreak can very quickly expand or go out of control, and it is more difficult then to contain once the cases are very large in number.
Yeah, and a lot of audiences are asking about the weather, whether warm weather will have an impact on slowing down the transmission. So what do you think about the weather?
Yeah.
And so, go ahead.
I think it is too early to tell at this point. I mean, this is a new virus. We don't know much about it. A lot of the transmission is going on in the winters in temperate countries, but at the same time, tropical and subtropical countries like Singapore and other countries in Southeast Asia are also reporting cases. So it is, I think, I wouldn't place my bet solely on the virus not spreading as quickly in warm climates. I think we'd rather be prepared and to deal with any possibility of spread. I think we need to wait until the middle of the year to see if there is indeed any effect in in warm weather and transmission. But what we see here in Singapore, in fact, the virus is very transmissible. We have had several fairly large clusters of cases, and this is usually due to a symptomatic individual being out in the community, going to work or going to different social activities that have spread the disease. So certainly I don't think warm weather alone can control its spread. So for countries either experiencing summer at the moment or in the sort of equatorial region, I don't think that we can just place our bets on the warm weather.
And a follow-up question on that from the audience from Nigeria asked the question about Africa, because whether the continent is ready to deal with that given a medical infrastructure. So you've been involved in a lot of global health initiatives. What do you think the death rate would be if the outbreak happens in Africa? And is it likely to be twice that of Italy, considering that people live in more of a communal societies?
Yeah, I mean, it's difficult to comment on things like death rates or predicting what will happen. I think that's I think going to be difficult to do under any circumstances. But I think the most important aspect about this disease is that I think we can control it if individuals are socially responsible and if they practice good hygiene, respiratory hygiene and hand hygiene. So, for example, in Singapore, we've been encouraging people, if you are ill, do not go out, go straight to see a doctor and self-isolate for the duration of symptoms. It's something that's very easy to do and you do not need a large healthcare infrastructure. Most of the cases, especially in younger individuals, are actually quite mild. And by doing that, we can actually reduce spread to the community and reduce the number of cases. So the factor of sort of impact on healthcare systems is twofold. One is how many cases there are, and secondly, how rapidly those cases are progressing. So if we can, what we call flatten the curve, and to reduce the number of cases, and also to spread them out across time, by simple measures such as being socially responsible, having physical distancing, and of course, having some testing capabilities to identify cases, especially the more severe ones, and to manage them in hospital, I think we should do quite well. And I know that Africa, for example, has been ramping up its testing capacity quite a bit. I wish my African friends and colleagues all the best in dealing with this threat.
And switch back to Dr. Peng again. A question about, again, healthcare workers. How did healthcare workers recycle or disinfect personal protective equipment intended for one-time use, given the lack of equipment is it's going to happen in a lot of places around the world? So how did you deal with that?
So actually, most of the PPE are disposable, except for the goggles. The goggles we just put in the container with the disinfectant with the alcohol, and then put the for longer time. I think probably it's okay for the for the virus, but only for goggles.
Only for the goggles.
Yes.
And another question is about how to avoid the false negative. There has been talk about effective swabbing and sampling, and some say that the nose is more preferable than the throat, or the swabs are best taken from the lower rather than higher in the throat with assistance of intubation. So what would you recommend? Because a false negative is really a very controversial problem in China, especially in February, I think. So
of course, if we can collect the samples from the lower part of the respiratory tracts, but without the intubation, it's difficult for us to get the samples. But if we intubate the patients, and then it's easily for us to collect the samples, through the the lavage. But without this procedure, we just collect sample with use the nose, the throat swab. But of course, this kind of the method, the sensitivity is quite low compared to the lower parts of the samples.
Yeah, and another question, switch to the early side. What markers were most sensitive and specific to predict early which patient will improve or deteriorate?
So actually, it's difficult to say, and we measured the only the IL-6 level for the patients. So if the IL-6 level is relatively high, also predict the much more severity and the worse outcome. And also, I mean, for the very simple markers, just for the the lymphocyte counts, if the patient with consistent lymphopenia, especially for the absolute counts quite low, so also predict the bad outcome.
And just now, Professor Lee mentioned about the community outbreak in Singapore. What is the attack rate of the disease in community setting? And is there a difference between attack rate in different demographics? Can you help answer that?
Sure. So of course, we have relatively few cases in Singapore. So there isn't a high attack rate or attack rate to speak of in the entire population. But what we have observed, if you look at the earlier slide on the reproductive number or the effective reproductive number in Singapore, is actually way below 1. And that's because about 70% of individuals that we have seen do not spread the disease to others. So it's a dead-end transmission. However, there are a few individuals that result in quite a bit of spread, mostly due to the fact that they are circulating in the public, such as, you know, they go to work or they go to activities when they are sick, when they are ill and symptomatic. And in those instances, the attack rate can be rather high. We've seen, you know, attack rates in the workplaces about, you know, they can range from 10% to even 30–40% in sort of small group meetings and so on. So what we are basically back to the same thing I'm encouraging is, if you're symptomatic, please stay away from, you know, such congregations of people to prevent spread. So there was another question on the age. So we have actually looked at our household context of cases, because in a household there is, I would say, good opportunity for exposure to the case in a household setting. So we've looked at the households and we've studied, I think, more than 800 household contexts. And what we've found is a very nice curve showing that the younger individuals are less likely to be infected, and the risk of infection or the probability of infection increases with age. So it seems that older people are getting are more susceptible both to infection and to also more severe infection. So one of the things that we've also been advising seniors and the elderly is to take necessary precautions and to reduce opportunities for spread, such as avoiding crowded places and taking good hygiene measures as well.
Right. Another question, a separate question is, could you please compare the pros and cons for mass testing versus targeted testing? Because we've seen that in different countries, taking different policies on that.
Correct. So, well, the testing methodology or the testing strategy for each country will differ, and it will differ on many different fronts. I think one of the main things is testing capacity. If there's no limit to testing capacity, sure, I think you can test everyone you like to out there. But most countries have a testing capacity. And I think every country will have to determine which is the most efficient and effective use of that testing capacity. If you test, for example, in certain settings where there's a higher yield, then you would be able to identify as many cases as possible. But in other settings where it may be, where there is, for example, widespread community transmission, or if you want to pick up as many cases as possible in a certain demographic or in a certain locality, and testing capability is not an issue, then of course you can do mass screening. But I think mass screening is going to be extremely, laborious and also requires a lot of resources. And the technology will make a difference as well. I mean, a lot of countries are now using PCR-based technologies, and this is not very amenable for mass testing. If there are new technologies such as point-of-care test kits or even serological tests that are being researched at the moment, this will certainly increase the capacity for mass testing. So I think we have to observe the technology and we have to see what is the best strategy for each country. In Singapore, we focus on the areas where we can get the highest yield. So for example, following our case definition, we're testing all pneumonia cases, we're testing all symptomatic contacts of cases, we're testing symptomatic people who are coming into the airport, and we're also testing people with respiratory symptoms who have prolonged recovery. So with all of this, actually, we are doing a lot of tests, but we maximize also the testing rate, because we think that even if we miss 1 or 2 cases in the community, at some point in time, we will pick them up when they either do not recover or if they result in a small cluster, let's say in a family. We will ultimately pick up the cases and we will do the contact tracing to then ring fence the whole outbreak.
Thank you, thank you. And Dr. Peng, there are more questions from the front line. Do you think, very detailed questions, do you think the PPE guidelines being forwarded by Public Health Department in Europe will suffice? And most notably, there's no hood in any of them, and hazmat overall suits usage is also low.
So actually, I regarding the PPE, I think it's so depends on the the what level of the protection. So if only for the for the droplet protection, I think it's just the the mask and the gowns and also goggle enough. But if for the for the procedures in the ICU, especially for the intubation, probably we need a better protection for the airborne protection. So probably we need the the hood, and also we need the face shield, and so but this is the this is the relatively high level of the protection for the for the airborne. So depends on the situation. But actually in China, I think it's the it's a little bit of over protection, because all the people, all the medical professionals, they wear the protective shoes. I don't think that the protective shoes is useful to all the medical staffs. But just depend on the situation. If the situation is in the very very high level of the precaution level, such as the airborne, probably we need to wear the protective shorts. Otherwise, the gown, the mask enough.
Many participants asked the question about traditional Chinese medicine. Did you use that to treat patients, and would it be possible to avoid herbal drug interaction?
So actually, honestly speaking, I never used the herbals in ICUs. Probably my colleagues in other departments, they use the Chinese medicine, use the herbals, just for the mild cases, to to prevent the mild cases transmitted to the severe cases. But in the ICU, we never use the Chinese medicine or herbals in our patients.
One question for both of you: after recovery, are there permanent damages to patients' health?
So actually, this is difficult to answer now. We need to follow the patients for a long time, at least for 1 year. So we do observe some patients discharged from hospital already, but still have the a little bit symptoms, such as the difficult breathing if exercise. So we need to follow up. So how long this situation can be improved, all this damage is permanent or not. So we need time to answer this question.
And we need time for more discussion as well. I'm just being mindful of the time. Actually, this is pretty much the end of our webinar, but I want to ask each one of you one final question, and don't panic, our participants online, because we recorded all your questions and we'll have them answered and put it online as well. We have I see on the Q&A box more than 70 questions, and there are a lot more in the chat box. So my final question for each one of you, I'll start with Professor Li. What are the key lessons you think your colleagues in other countries should be aware of? If you name a few.
Sure. I think one of the things is basically to be prepared. Do not underestimate this virus or how fast it can spread. I think countries should be prepared to do a few things. Number one is, and I will emphasize again, identify as many cases as possible, isolate cases, whether in hospitals or at home, depending on the capacity, and also to perform contact tracing to identify more cases and to ring fence the outbreak. Secondly, I think communications to the public is very important to empower individuals, to make them feel that they are in control of the situation. And this is what we have done to try to tell the public that if they employ good hygiene, if they are socially responsible, they protect not only themselves, but also their loved ones and their friends, and also to employ physical distancing measures to protect themselves. I think if we can empower the public, I think that's going to be really important. And the third is to have a good surveillance system so that we can look at the progression of the pandemic and to then roll out measures that are proportional to the impact of the outbreak in a local setting. And finally, the most important, I think, is a global collaboration. I think the more information that we can share, the more data that we can share, we will be better, I think, able to respond to this threat globally. And I really want to thank you for hosting this webinar, because this is actually how we can share as much information as possible to as many people and to keep that collaboration going. So thank you so much.
Thank you. Then that's exactly the purpose we're holding this webinar. And I want to end with Dr. Peng. One question, or you can say that in two. I want to end with a personal note. Looking back and knowing what you know now, is there anything you wish you could have done differently? And the second question is, what was the toughest choice you had to make in the last 2 months?
Okay, so so if the time could go back, so I would focus much more on the non-protective ventilation strategy. So try to avoid the further lung damage by the mechanical ventilation. So this is very important for our patients, and because these patients they have a lung injury already, so don't let the lung further damage. So by the appropriate mechanical ventilation, and also what's the next question?
What was the toughest choice you made?
What was a tough choice? So this is the very tough for us, because in the early stage, the ICU resources was not enough, and we have to give up. We have to because the patients, a lot of patients waiting for waiting for during the waiting time for the ICU beds. So this is a way. This is the tough period for me in the whole life. So I still couldn't remember this very bad situation. Mm. So so still the very good, very important lesson we learn is to try to mobilize the medical resources for our patients. So especially in the early stage of the outbreak, and try to organize more ICUs, organize all the the medical beds for our patients. This is quite important for the patients.
Thank you.
Okay, thank you very much for inviting me.
Yeah, thank you for sharing with us. I think if there's one lesson for us to take away, be prepared and act as early as possible. And I hope that others can benefit from that. So many thanks to speakers, many thanks to our participants. And I'm sure we cannot hear it, but you're joining me to give a round of applause to the two doctors fighting in different but equally important fronts. You had early victory, and I hope we all win at the end. Thank you very much for your time, and we look forward to meet you again in future Caixin Global webinars.
Thank you so much.
Thank you so much.
Thank you.
And for the participants, please come back and get the materials online.